if you're in Italy, like our dear friend, Dr. Silvia Priori, who is our special guest, a very special guest and a very dear friend of mine. Silvia, welcome to SADS Facebook Live.
Thank you, Mike. It's a pleasure to be here. And hello, everybody.
Well, we are back with you to try to meet your needs. And on behalf of Alice Laura, the CEO of the SADS Foundation, welcome. Thanks for choosing to spend the next 40 minutes with us. If you missed out and don't know whose voice you're hearing, I'm Mike Ackerman, a genetic cardiologist at Mayo Clinic and president of the board of SADS. And we're in 2 months plus. And I was just looking, Silvia, the last time I saw my granddaughter was February 16th. My last flight was February 28th, flying back from New York, of all places, after giving grand rounds. So I've been at home in Rochester for over 60 days. For COVID-19, we have crossed the 3 million mark, 3,300,000 cases worldwide. Tragically, 234,000 deaths. And for those of us in the United States, we now have crossed 1 million cases and 63,000 deaths. And in Dr. Priori's country, there have been over 205,000 cases recorded and 28,000 deaths. So given that we in the United States are 5 times larger in population, our dear friends in Italy have been hit really hard. And Silvia, we think of you, I've been thinking about you and your sons, and give the SADS Facebook community a feel of what is life like in Italy right now.
Well, right now, we say that things are getting better, but still we have 100,000 positive people, estimated more, but counted 100,000. And in total, we have had, as you said, 200,000 cases. The worst is the 30,000 deaths that we have had. And, life has changed a lot with these social restrictions that have been enforced quite in a hard way. And I have to say that it was only when they forced us to stay home and go out. Of course, physicians could go out, but everybody else was inside, that then things started going down and improving. So it seems illogical with modern medicine that to beat the virus, the only thing you have to do is to stay home. But it actually worked. So at least, the difficulty of doing it has been compensated by the fact that it has decreased to this famous R0. That means that we are really controlling the thing, and then the rate of spreading from one person to the other person is below 1, and that means obviously that we are not infecting a lot of people. So we hope on Monday we will reopen many activities, and we think that this will be an important test for the world. We were the first in Europe and in the Western world to have the virus, and we will be the first one to really open the country. And so I hope that we can show the world that everybody, will be able shortly to do it.
Well, thanks, Silvia. I'm wondering, about a month ago, probably 6 weeks ago, there was tremendous anxiety in the SADS community of our families with genetic heart rhythm diseases, the channelopathies, the ones that you and I love. When the paper came out saying that patients with heart disease, that they do poorly or they do worse with COVID-19. And that caused really a firestorm of angst in our community of our families calling up and saying, is long QT syndrome heart disease? Is CPVT one of those heart diseases? And so we had to do a lot of work. And I wonder what kind of questions that you have been receiving from your families, or what have been the 2 or 3 most important messages that you and your team have been giving your families during this time?
Yeah, first of all, of course, we have enforced and motivated them to stay home and to remain distant, to continue on their medications. For us, we have a lot of patients who are on nadolol that may be not found everywhere. So we managed to provide them, to ship to them the drug. Mexiletine is the same. So we created a network for them to be sure that even if the pharmacy could not get it, we could get it for them. And then, the issue of whether they are more predisposed, we really told them that what it seems is that is mainly on the person who have chronic diseases rather than patients with structurally normal heart, as most of our patients with the channelopathies are. We had more concern, of course, for the patients with the cardiomyopathy, especially if they have heart failure, because then they go in the other category, that is a structural heart disease. So more recently, then, when the patient started having the disease with long QT, having the disease with cardiomyopathies, we started trying to inform them of the need to advise the clinicians who are taking care of the family member with the disease about the possible effect of the medication that can prolong the QT, that can lead to hypokalemia. And so, we have tried to be with them and manage them, but obviously the anxiety remains high every time the patients hear cardiac patients have a worse prognosis. And, obviously the newspaper, the TV cannot make the distinctions, but we have not got a signal that our patients have been very affected. In fact, the number of patients that reported to us being affected, is like 5 or 6 so far of the 1,000 of patients that we are following.
Yeah, and I think that's incredibly encouraging, isn't it? That our families, I know at the SADS Foundation, they haven't had a case of symptomatic COVID-19 in our 1,000 patients that we're following. We haven't received a call yet of a patient with symptomatic disease. Now, whether or not they've had the SARS-CoV-2 infection and have tested positive by PCR but are doing fine, they may have chosen not to engage us or contact us, but we know that the rate of symptomatic coronavirus disease in our genetic heart rhythm family seems to be incredibly low, and I think that's great news for our families.
Yeah.
The questions are starting to come in, and so for those of you out there in the SADS community, thanks for joining us and thanks for your questions, and Dr. Priori and I are going to start to dive in. So you'll see my eye contact leave the screen as I scroll your questions. Remember, question etiquette, make them a little bit tight and short so that I can read fast and give them to Dr. Priori for her and I to chew on. And we'll start with this one from Stephanie. So Stephanie, thanks. And Silvia, Stephanie's wondering if we know of any cardiac side effects or issues with the Gilead Science drug remdesivir.
Now, for us, it's still a drug that has been limited to clinical trials, and clinical trials, for what we know, have not enrolled patients with our inherited arrhythmia. So we have really no experience, no direct, not reported by other centers. So we'll see now that the drug will be approved. In the US, is already approved by FDA, and so you will have it for practice, right?
Well, right now it's still predominantly under trial,
Okay.
clinical trial, and there's an emergency use authorization approval type arrangement. And that may be, and we'll come back to some of the treatments because I'll be curious, you like me, we read what's going on with the therapies that are being trialed and proposed and considered, and we're not infectious disease experts, but we have a very significant interest in the therapies, and maybe we'll circle back towards the end on what your read on the therapies that seem encouraging or attractive. So Stephanie, thanks for that. Remdesivir, the heart doesn't have to worry about it, and that's good. Claudia, hello from Austria. She's wondering about CPVT. Mm-hmm. And do our patients with CPVT need to be uniquely concerned about getting infected with SARS-CoV-2, and will it be worse on the CPVT heart? What's your thoughts on that?
We have not had any single patient that has contacted us with the CPVT, even if we have the family members that are older and have the mutation. So we are covering within this disease also a population of affected individuals of a more advanced age, but no one has contacted us, and this gives the signal that obviously most likely as everybody else, they can get infected, but no signal that they are extra symptomatic, more symptomatic than the general population. We know that with COVID, a very high proportion of individuals have the disease in a totally asymptomatic way. So, and this is good because there are certain categories at higher risk where the asymptomatic are very small, like the cardiac patients, diabetic patients, and the elderly. So I think that we are good with CPVT. We have no signal of worsening or higher risk. And is the same for you, Mike?
It is. We haven't seen it. I haven't had a single CPVT case either. So I think, I guess we could always make the argument that what we tell our Brugada patients, if they get a febrile illness, lower the fever. I tell my CPVT patients, if they get a fever, febrile illness, lower the fever as well, because maybe the heart rate speeds up more with the adrenaline of fever, and a little extra Tylenol doesn't hurt for fever reduction. So, but I haven't seen it at all either.
Yeah.
Speaking of Brugada, Jan is wondering about the state of Brugada syndrome in Italy, as she was told that there's been high numbers among the Italians. And I don't know if she means high numbers of Brugada syndrome in Italy or high numbers of Brugada patients having COVID-19 complications. What's your thoughts?
Well, I presumed she means that there are a lot of Brugada patients in Italy, because this is something that has been said over and over even in the scientific press, and so probably is what she says, because I don't get any signal that Brugada have been infected more than any other patients. Even if in Brugada one might think that there is a predisposition because of the high number of males that are diagnosed with Brugada because it's more symptomatic in them. But again, even from the Brugada, we have not heard any excess of occurrence of the disease in a symptomatic form.
And then Silvia and I will give a shout back out to Lorraine from Ireland, a PhD researcher. Thanks for joining us. And Christine from South Carolina. I love CPVT moms. But here's one from Jenny Kostecki, and this is probably relevant to both us in the United States and in Italy and throughout the world. And it's about shortage of blood donations and the needs of the hospitals to get increase in blood supply of the donors. And she's wondering, is it safe for long QT patients to donate blood, or any of our channelopathy patients to be blood donors? What do you tell your families about being a blood donor?
In Italy, they cannot donate because anyone with any form of disease, congenital or acquired, cannot donate.
Isn't that interesting?
Yeah.
Yeah, so Jenny, in the United States, you can be a blood donor. So because there's no risk of transmitting your long QT via the blood. And so you could be a blood donor. We know that blood donations are safe. The patients are screened with COVID-19 questionnaires. So I don't think any of our SADS families need to be afraid to go to a blood donor site if it's permitted in your country. Yeah. And we do need blood donations. And we probably need plasma donations. But maybe, speaking of plasma donations, Sylvia, we have become one of the headquarters sites or the principal sites for this whole convalescent plasma antibody therapy. And I'm not sure what I think of it yet as to whether that's going to have a great therapeutic signal. But what are you and your colleagues' thoughts about getting the plasma from patients who have already cleared their COVID-19, potentially have treatable or therapeutic antibodies? Are you guys exploring that? What's your thoughts about?
Yeah, actually, Pavia is the center in Italy that has pioneered these, and so we are actively doing actually all the physicians who are positive and the antibodies. I will do the test on Monday, so finger crossed. So all the ones that are positive donate the blood. You donate 600 ml of blood, and then they make a package for treating one person out of you doctor or any other person donating the plasma. And the results seems encouraging, but it's not randomized, it's not a control study yet. So, but it's a hope.
Yeah, I think it is
Do you
hopeful.
have an idea of the percentage of individuals in the US that are positive to the antibodies?
That's a great question. I haven't seen that. What has been the serologic tests are just starting to really get rolled out, and I missed the coronavirus task force update from the CDC yesterday. So I'm not sure what the rate of seroconversion. So like you said, I could be positive with antibodies, and I don't know it because as we've seen, 40 to 50% of all people infected with the virus don't even know that they were infected, and yet they generated an antibody response, and they might have therapeutic antibodies for a future patient.
So we have a 15% of physicians in the hospital that are positive, which is very low.
Wow, wow.
So now
Yeah,
the question is whether physicians are not exposed because they wear all the mask, the body coverage, and so on, or whether there is an incomplete response. Not everybody gets positive. So
right. And hopefully it's not that one.
yeah, hopefully it's not.
But maybe the universal masking, I imagine you are, when you go back on Monday to your clinic, are you guys you will be masked, your patient will be masked?
Yeah, yeah.
Yeah. So we've done that. We've been in a universal masking here at Mayo Clinic for probably 4 weeks as I started to see patients again.
Mhm.
And there's so far good news. There hasn't been a single example of a patient to physician exposure or getting infected, or an asymptomatic physician exposing and infecting a patient. So the you be masked, I be masked, we all be masked together seems to be a good idea for now.
Yeah.
Janine's asking a really good question because it's going to be dealing with what's life going to be like on the other side of summer when we go back to school and our kids go back to school, hopefully. And her 13-year-old son has long QT. He's an asthmatic and living in New York City. And if the schools reopen in September, which is generally when we go back to school in the United States, would you advise them to attend school? This gets to that whole area of should we as physicians be providing accommodation for certain health situations to keep them quarantined or socially distanced longer? How are you guys thinking about that issue?
Yeah, we have had a big discussion now because the question was if we are opening on Monday and parents have to go back to work, how is the situation? Because in Italy, a lot of parents let the little child stay with the grandmother and grandfather, which is no longer an option now because of the risk of the older people to get sick. So the schools are not opening right now. But in the September, of course, they will reopen, and I think that the idea of moving it in September is to get more information on what happens to the youngest, because right now the focus of investigation has been not in the pediatrics but in the adult. So
Right.
now there are more data coming out showing that maybe the infants have the risk of Kawasaki, COVID-related Kawasaki, but maybe the adolescents are really the niche that really has the good balance, between not having the risk of the super young, of these specific endothelial diseases and vasculitis, and on the other side, not having the risk of the adult. So I think they would be safe to go back to school.
And I think a follow-up on that, Sylvia, is Ryan from the United Kingdom has Brugada syndrome, and he's been told, it's an interesting one, to self-isolate for 3 months because he has Brugada and being classified as high risk. And he's wondering what happens when the 3 months are up. Is it safe to go back out, or will he get told to isolate for longer? Are you telling your Brugada patients to self-isolate for 3 months because they have the diagnosis of Brugada syndrome?
No, we are saying everybody with channelopathies that there is no evidence whatsoever that they are at higher risk. And the fact that their heart is structurally normal, that they don't have any dilatation, any functional abnormality, that they can have a normal life. So, I mean, we have a different policy. So I think it's interesting the second part, what happened when the isolation period is over, because this concerns everybody, you know, quarantine, how long is quarantine? And as long as you make it, the longer you make it, then the more severe is the question. And now that I go out and I'm definitely not encountered the virus, so I'm sure I don't have antibodies because I've been inside. Am I at higher risk to get it now? And
Right.
there is no answer really to the question. But I think that the patients should follow the advice of the physicians that give this recommendation. And
Yeah. And I think it's probably worth it, Ryan. I think it's a great question for you to check with your specialist to see, is there something unique about your situation that has prompted that? And maybe he or she has saw something in your particular healthcare situation where they have felt that that might be a good idea. I'm going to quickly take Sonia. Sonia has been patient with us for the last several weeks because she has a unique question. Her family has TRDN mediated disease, or Triadin, what we've called Triadin knockout syndrome, and is wondering about myotonic dystrophy being misdiagnosed as dyspraxia. So that's a big question that probably most of our audience has no idea what that sentence means. It's probably a little hard for even me to know what that sentence means, but I'll give you the quick and short of it, Sonia, and we can talk more later. But we have started to see that patients with Triadin knockout syndrome, that the loss of that Triadin protein on both copies, from mom's copy and dad's copy, does have a subtle skeletal muscle phenotype, a muscular weakness. And it may be more than subtle. It's just that we cardiologists doing a skeletal muscle exam didn't notice it as well. Now that we start having our neurologists do a neuromuscular assessment of our patients with your form of channelopathy, that of Triadin knockout syndrome, we're starting to see some evidence of skeletal muscle weakness. Nothing dramatic, nothing like muscular dystrophy, but it's there. Anything to add on that, Silvia?
yeah, I would say, you know, if the question is really to the point whether these muscular phenotypes of triadin can be confused with the diagnosis of dyspraxia, I would say that no, because dyspraxia has also a lot to do with coordination of the movement, and therefore that is definitely not a phenotype that we have in triadin. Of course, a child that cannot walk very well, that is not very active because has some weakness of the muscle, may seem a child with any of the skeletal muscle disease, but maybe not really dyspraxia because of the normal coordination. At least I have seen some patients that feel that they get tired when they walk. I mean, obviously, no one has experience with 20 or 60 patients with triadin because it's very rare. So now that, Mike, you have put together the registry, maybe you have a broader view, but in my sense is that there is a minority who have this muscular phenotype.
Yeah, absolutely.
And is weakness
And
predominant.
its weakness, yeah. So thanks for that, Sonia. And we have some really good questions for a new future program idea. And I think, Mohammed, thanks for that suggestion of having a SADS Facebook Live for our heart rhythm specialists who are trying to deal with interesting genetic heart rhythm cases for management. Because I think Mohammed knows, and Sylvia, you and I have talked about this a lot, that the typical pediatric and adult heart rhythm specialists, they're phenomenal, but these particular diseases, long QT syndrome, CPVT, Brugada syndrome, are not in the sweet spot of what they do every day. And it gets to be pretty nuanced. And so maybe I can get you to join me again sometime, Sylvia, where we'll have a session with the caregivers and the specialists to brainstorm some of the cases that they're being vexed by.
Yeah, that could be fun.
That would be fun. Let's see here. Oh, this is a good one, Mary. And it's a good one because Dr. Priori and her team just published a pretty impressive, not pretty, and impressive paper on Andersen-Tawil syndrome. And so Mary's asking about Andersen-Tawil syndrome, and are they at more risk in terms of myotonia and periodic paralysis? And maybe we'll extend beyond that to Silvia. Anything that you think the Andersen-Tawil syndrome patients need to be thinking about uniquely or differently because of their gene and CPVT, and COVID-19, or not so much? Same thing.
Well, I think that we don't have any information so far that patients with skeletal muscle disorders are at higher risk. For the cardiac component, the Andersen-Tawil are like any other channelopathy with a heart that predominantly is normal, and especially is not developing the heart failure or the phenotype of myocarditis that are the two key. They don't have hypertension, and they don't have metabolic disorders like diabetes that are the key factors associated with risk of COVID. So I would say that they are quite safe. There are we have two patients with Andersen-Tawil and dilated cardiomyopathy, but is a mixed phenotype that is not typical of Andersen-Tawil. So we are not sure whether, they have two separate diseases coexisting. Yeah. So in that case, of course, like you were saying to the Brugada patients, maybe he has been told by the physician to stay home 3 months, because he had some other phenotype and not only the Brugada. So here is the same, if the Andersen-Tawil patient have any other phenotype, then they might be at risk for that. So the importance is to discuss with the physician the characteristic of the specific disease, and if it's only the channelopathy phenotype with the skeletal muscle weakness, I think that again, for the data that we have so far, they are in the category with the risk of a normal population.
Great. And I'll come back to Stephanie's question about remdesivir. And Silvia, as you look at the landscape of treatments that are being used, explored, offered, which treatments, and again, Silvia and I were not infectious disease experts, but we are cardiovascular scientists, and we know how to critically look at the literature and the data, and we talk to our infectious disease colleagues a lot. But with that disclaimer, what therapies are you kind of encouraged by, or are you envisioning that you have some hope or optimism in? What do you think about the treatment landscape for this virus right now?
So I think that both remdesivir and hydroxychloroquine are the two that are higher up in the list of the potential effective or partially effective or signal of efficacy medications. And the problem is that both seems to be more effective if given very early on at the diagnosis, before the severe symptoms appear. So, of course, it's very good to have them, but there is some concern on what happens when the patients are in the later phase. But I think that this last week has been quite encouraging in showing signals that these two medications could be impacting in a positive way the disease. For remdesivir, we have no information. I don't know if you have it, but I don't have information if it prolongs the QT, if it blocks hERG. For the hydroxychloroquine, what I want to say is that it is true that it's a blocker of hERG, but on the other side, we have to keep in mind that the treatment of hydroxychloroquine is given for 5 to 10 days. And so if the patients are on monitoring of the electrocardiogram, especially if the drug is conclusively proven effective in treating the disease and in improving the disease, I think that the long QT patient would not have to think of themselves, I could never get that because it prolongs the QT. Of course, they will have to be in the hospital, not at home with the drug, carefully monitored. But as an average of 150 patients, not long QT patients, but normal patients in which we have had hydroxychloroquine therapy, we have seen a mean prolongation of 20 milliseconds over a 5 days period. So it's not so bad. It doesn't mean that we need not to care and take it at home just by ourselves. But right. I see more from the point of view that we will not be telling, oh no, there is long QT, you cannot be treated with a medication that is effective in COVID. So it's
Yeah, and I think your point there is really important, that if there's benefit and we have confidence in the efficacy, that we can safely navigate the use of it by monitoring our patients closely. Nobody should give our patients these drugs willy-nilly. Otherwise, it will snake bite them. And the hydroxychloroquine, the way you described it being used, is very different than the so-called high-dose Brazilian Corona cocktail, which was very dangerous. But those were really high doses.
Yeah.
Of chloroquine. And so I think we need to wait to see, but I'm not afraid to use this drug if we were to get confidence in the efficacy signal. But I think as long as our families can stay corona free out there, the longer the better, because we're learning more and more each week.
Yeah, but definitely, I think it's important that we tell our patients, if you're a long QT, you don't take it right now. But if the data are confirmed that it's effective, don't feel that there is a good drug and you will never get it. You can still get it.
I think that's really, really important. And I love that. So I think it's the first time we've had it communicated that way over the last 5 weeks. And I think that just shows what's been the evolution of our understanding of these drugs. And so stay tuned out there, everybody. We'll be keeping you posted as best we know it as to what therapies are working. But again, until then, we all do our part to stay masked, stay distant, 6 feet apart, wash your hands a lot, soap and water. The virus hates soap with hot water. And the longer we stay corona free, the better, because we are learning what's working. In fact, the working part has been amazing. When we first saw, Silvia, the rates of death, that if you were hospitalized and you got intubated, it made it seem like it was a death sentence, 75, 80% mortality early on. And our experience here and in Hopkins and in other major centers in the US, not New York City, where they've gotten overwhelmed, the mortality rate of the hospitalized sick COVID-19 patient is under 5% here. So I think it's the difference of when you get overrun versus when you can methodically, thoughtfully take care of the patients. What are you guys seeing now for your hospitalized patients? I bet you the mortality rate is nowhere near what it was in northern.
It's not near what it was. Obviously, the patients now are taken to the hospital early on, so there is a smaller number that gets intubated, a smaller percentage that dies. But tell me, what do you think of this concept that Dr. Fauci mentioned in one of the interviews, that maybe in California the virus is less aggressive because there is a mutation, and that in the US you have genetic variants, not only of patients, but also of viruses?
Yeah, I think it's interesting. I don't know what's the reason behind that. I think they're trying to account for why did it not get overrun in California, where there's a high rate of population density. But I think one of the reasons might have been it didn't get seeded. So the SARS-CoV-2 traffic from China to the United States got shut down very early. Traffic from China to northern Italy did not, and then from northern Italy, Milan to New York City continued. And I personally think that that's kind of what seeded the places, and Los Angeles did, because Los Angeles is a pretty population dense area that just did not get hit like New York City did. And whether there's a genetic variant of the virus there, I don't know. It's interesting.
Yeah, and Madrid is another one that didn't close early on and was badly hit.
Right, and our colleagues in Spain, boy, they've really, and it doesn't seem like it has settled down there like it has for you guys already, or is it getting better?
They are opening the following week on the 11th.
Okay.
So it's getting better now.
Well, Silvia, this has been fantastic. We have a few minutes, and maybe I could just ask you, since we've been isolated in quarantine and some of our labs have been shut down, it gives a lot of us time to think and brainstorm as to what research questions are really exciting you, what you're passionate about, what are you going to sort of devote energy to answering when the labs are up and running full speed. So share with our SADS Facebook Live one or two of the research questions that you're really keen on right now?
Yeah, right now, as you know, our major efforts and dedication is for the new therapies. So, especially for the gene therapy, we are now struggling to see whether we can develop new viruses that don't have the problem of being killed. Viruses that carry the gene therapy, so good viruses, not viruses that infect the heart. So is a therapy that can solve the problem, that can compensate for the genetic defect. So it's a fantastic thing. But right now, unfortunately, human beings have the antibodies against these viruses that are used for gene therapy. So we are now trying to develop new viruses that would be not already known to our body, and so not responsive with therapy to the therapy with the antibody to reduce the effect. So a lot of work now is going in immunology.
Wow.
So we are changing and going toward other different things. And then the other is, of course, to try to understand better the mechanism of Brugada, that remains still one of the most elusive issue in the field. Why is only the outflow tract, and why certain mutations are more severe, even if they are not obviously more expressed or more implicated in the slowing of conduction and so on. Are you doing ablation at your center?
For yes, not, we don't have very many though. So certainly, and we're definitely not doing prophylactic ablation.
That's important not to do it. I agree.
Well, Silvia, this has been wonderful. I know when you had technical difficulties and couldn't join us, I don't know if you heard me share with the SADS Facebook Live that I view you as the queen of cardiac channelopathies, and you and I'm not sure that gives you full credit for everything by focusing on the presence of two X chromosomes that gives you the title queen, but you have been an amazing colleague. What you've done in our field is really unprecedented, and more than that, you just have been a gem of a friend and colleague. So, Silvia, thanks so much for joining us and spending your evening with us. And I think she might have just hit the button that said goodbye inadvertently, because I saw her click on something. So with that, I'm going to show you guys something. You've been watching Jade and Ruby Lorraine grow up. Look at that. Look at that. That's her 3-month-old picture yesterday. So, oh, there, she's back. So now you're going to see her. And I thought you disconnected on a compliment.
Yeah, I blushed and the camera disconnected. Thank you for all your compliments and congratulations for all your work, but especially for being a grandfather.
Yeah, thank you. I love it. And all of you out there, take care, stay safe. If you go out in public, be masked, keep your distance, wash your hands, and do not fear. Be anxious for nothing. We'll all get through this together. Take care, everyone.
Bye.